Good evening, everyone, on this fine evening. Thank you for joining me on this webinar on the topic of bone grafting. It's an overview of bone grafting, and I'll also be touching on how to make retainers with pontics as a temporary measure to temporize your patients after a bone graft, hopefully with the aim of placing implants, of course. So my name, as you can see, is Dr. Sayed Nazimi. You can see me twice here on the screen. And this is my email on Instagram, should you wish to email me or follow me on Instagram. I post a lot of educational cases on Instagram, and we can discuss things there as well. And I'm a member of the ADI, which is the Association of Dental Implantology. They're a great association, of the other one being the ITI, of course. And I place Ostem implants, and I use Ostem systems. S4S Lab is also involved in this lecture, and you'll see why towards the end. We've got some great offers from them. So taking referrals, well, mainly I work as on a referral basis for these topics: oral surgery, wisdom teeth, any impacted teeth, crown lengthening, functional anesthetic. I do periodontal treatments, non-surgical as well as surgical. And this topic obviously is about bone grafting becoming more and more a topic that's needed for us dentists who are doing implants, but it can also be used for other cases, as you'll see. And of course, I also receive referrals for implants, so I'd be happy to discuss that with you should you wish to refer any cases. So to gain your CPD credits, today you'll get 1.5 hours. If you haven't already filled out the online form, then I need you to message with your full name, your email address, your personal one rather than the practice, because we often find that CPD forms go astray if you give us the practice email. So give us your personal one, your GDC number, of course, for the certificate, and then we will send you your CPD feedback questionnaire, which I'm required to receive back before I can issue your CPD. I'll also send you a PDF of the lecture and some referral packs. S4S Lab will also send you an intro pack and 50% discount on your first case. If you don't want this, please do let me know in advance. Thank you. So a bit of housekeeping from Mr. Bean to start with. And if I can ask just to put your mobile phones on silent so there's no distractions. If you could turn your microphones off so that we've got a nice sound, and no videos of the lecture, please. I will of course give you access to this video, but you are permitted to take short videos or photos for social media purposes. So a bit about me and the travels I've done. Koh Phi Phi is a place that I hold dear to my heart. Unfortunately, it's becoming very touristy these days, but I started my travels in Thailand back in something like 2003, and I initially went to the north in Chiang Mai. If I can bring this up and show you. So Chiang Mai is this region in the north where the mountains are. Because I don't deal with the heat very well, I went to the mountains and I was training Muay Thai there for some months. There's lots of beautiful regions there to see. I've also been to the areas, of course, Bangkok, where most people start in. And of course, most people actually go to these areas, the islands in the Gulf of Thailand, in this region. But this scene is my morning view in Koh Phi Phi. This is where I did my dive master, and I'll just show you where Koh Phi Phi is. Of course, you've got the island. It's not quite, it's more of a peninsula, Phuket, but then you've got the Straits of Malacca down here, and there's a tiny island in between, which I'll bring up in blue here. It's called the Koh Phi Phi Island. And travelers often go to that area, as well as Krabi next door. And it's a gorgeous island. Just around the corner of that was where Leonardo DiCaprio filmed his that film. What was it, The Beach or something along those lines? But Koh Phi Phi, as you can see, is a gorgeous island. And this was my morning view from my villa. This is me on the boat going out to the dive sites, and this is our stop for lunch. This here is a what's called a pipefish. These are bottom-dwelling creatures. You often find them on the floor of the ocean, and they are it look like reeds, right? So you wouldn't think that that's a fish, but you can. They're in the same family as seahorses, actually. So you can see just about in the head that it kind of looks like a long, overstretched seahorse. But I love these things because they're so hard to find, and they mimic other things in nature. So often, as you go into more and more diving, you start to appreciate the smaller, refined things rather than the big species. And of course, we've got Nemo here. Nemos, they often live in anemones, and anemones are these spiky plants which essentially they actually sting, so you're not meant to touch them, and most species can't go near them. And this is why the clownfish, or Nemo as they're called, like to hide in there because the anemone protects it. A lovely situation of symbiosis. We see creatures living together, helping each other. And this was a photo of me doing some free diving. Free diving, of course, is where you take a long breath and go down, and you dive free without a tank. And in this sort of situation, it's much more peaceful. You don't have all the sounds of the metal clanking around on your back when you go scuba diving, and you don't have any air bubbles jutting out. So it's a much more peaceful experience. You can get a lot closer to sea life, and this is a moray eel. I'm much closer to it than that's the eel would usually allow if I was scuba diving with a big tank. And this is a photo of me surfacing to the surface. So on with that, and my dental career, it's important that you know a bit of history about me. Well, I graduated in Newcastle in 2009. I did a year of Max Fax and VT. And then I went on to do some postgraduate training so to get the MJDF qualification. And then I became an ACL at the Newcastle Dental Hospital, helping students on clinic. And then I started my private training and going through multiple courses. Chris Orr was a huge help for me in 2014. I'd recommend his course to anyone. And then I went to do my second biggest, most important course, which I'd say was the implant surgery with the practical implantology team, or the PI team as they're known. This is Dr. Soni, Dr. Sheikh, and Dr. Mohammed. They're amazing lecturers, and I learned so much from them, and they were the start of my implant and bone grafting journey. I then went on to do some prosthetic training and then other courses such as bone manipulation, GBR, GTR training, Dr. Rob Oretti, some perio training with Dr. Ian Dunn, and then I did a diploma in implants, and currently I'm doing Reno Wadia's perio PG dip. So this is a bit of history of all the other courses that I've done, but I won't dwell on that too much, and we'll speed on with the lecture. So today's lecture, bone grafting, and what are the contexts? Well, first of all, we're going to talk about what is bone grafting, why is it done, when do we graft, the occlusal and bone changes after extractions, buccal bone after extractions in particular, the concept of alveolar ridge preservation, or ARP. I'm going to give you a case example of ARP, types of bone grafts that we have available, how bone grafting works, the role of barrier membranes, and then I'm going to talk to you about anterior temporization, how to temporize the area where the tooth is missing, the referral process, and S4S lab introduction, and we're going to finish with some questions and answers. So this is Professor Araujo from Brazil. He was one of the first dental pioneers in bone grafting. Of course, the orthopedic surgeons were doing bone grafting before the dentists, but in 2005, he did a very important study on bone changes after extractions on dogs, and he documented how much bone we lose and how we lose that bone, in which positions of the bone. So dental bone grafting, first of all, what is it? Well, The first bone graft was actually placed on a Russian man who had a cranial bone defect. It was restored with dog bone, and that was in 1668. You can see how far back the orthopedic surgeons go. Dental bone grafting now is a surgical procedure to replace lost or missing bone in the alveolus. And this is an example. Obviously, we've got a block of bone being placed into an area where we're missing, and then we've also got granular bone grafts as well. And so why do we bone graft? Well, we do it to fill a horizontal or vertical defect in the jawbone, the alveolus, to support, well, what are we supporting? We're either supporting teeth, or we're supporting implants, or we're going to do it for bridge pontic aesthetics so that we don't have to have a huge pontic where we've had that huge amount of gum and bone recession. So let's look at CBCT views as an axial view looking top down or bottom up actually, and we can see that how thin the bone is in the extraction sites here and here, okay, where the body of the jawbone has not been followed and it's shrunk away. And then we look at horizontal defects in the mouth. This is what it looks like, of course, the ridge width being sort of closer to here on the premolars, and then suddenly in the molars it's narrowing down to here, okay, and you've got this sort of knife edge, sort of like Scarfell Pike if anyone does hiking in the Lake Districts. So why do we bone graft? Well, also vertical defects, and you can see here an extraction and we've got a vertical defect there, and then we also develop really bad vertical defects over time. You can see here 9 millimeters loss in the mandible. So when do we do grafting? Well, we can do it at tooth extraction stage. This is called ARP, alveolar ridge preservation. So we take the tooth out, we clean the socket, we place the bone graft, and usually a cover or something to protect the bone graft. We can do it after tooth extraction. This is called staged grafting. So the tooth has come out, we've lost bone, and then we place bone later. In this situation, we're showing you a block, but it can be in other forms as well. At implant placement, we can do bone grafting. So this is called GBR, guided bone regeneration. And you can see that the implant has been placed, that there's a defect in the apex of the implant, and we need to graft in this region to protect the implant. We can also do it to fill a bony infection defect at the tooth or implant level. So we've got bone loss here on that lower left 6, and we can graft in that area for the tooth. If we're doing for the teeth, it's called GTR, guided tissue regeneration. Around implants is called guided bone regeneration, GBR. So occlusal changes after extractions. Well, what happens to the jawbone in terms of the bite? What happens to the occlusion when we take a tooth out? Where we get tipping of the adjacent teeth. I often show my hands. I show the patients that over time your teeth will tip into the gap, and that opposite tooth will grow down into the gap, leading to a situation where it's uncleansable and risk of cavities can occur. Usually it takes 5+ years for this to occur to a significant amount, by which time it can be too late to restore the area unless you do braces and pull the teeth back, which is obviously going to take even longer. You also get wear and tear of the other teeth is increased as the other teeth are having to take more of a load. I often say to patients that it's like a minivan with 8 wheels, losing 2 of them, you're now down to 6. The other 6 are having to do more work. And there we are, yeah, the lorry analogy, minivan. What you need to do is show and explain these changes to patients so that they understand what we're talking about. Obviously, when I often use images is a great tool, and you can see here a situation where a patient didn't restore their lower molars, and the upper molars have completely come down, and she came to me because of pain from the upper 8. And of course, the other point is that those teeth are non-functional. They're just sitting there supporting the bone. They're not actually chewing on anything. Yeah. So without this knowledge, patients can't make an informed choice. So it's our role to inform and educate the patients on that. And the number of times you'll find that patients' opinions changes, and a patient who maybe didn't appreciate something previously, once you showed and explained it to them, really appreciates your point of view and now wants to engage in that better care to provide them with an implant or other device. So the bone changes after extractions. What happens to the bone? Most bone loss occurs by 6 months. And progressive bone loss, however, does occur over time beyond 6 months, and you do get remodeling for life. Usually, if a patient is, for example, with a removable prosthesis such as the denture, I often say to patients that you've got to wait 6 months for 100% healing before you consider your denture. At 3 months, it's usually about 80% healing. So I don't like to go in with a removable prosthesis at 3 months, because by 6 months there will have been more shrinkage. Now let's talk to you about the bundle bone. What is the bundle bone? This is really important for extractions and implants. So it's the part of the alveolar bone that surrounds the teeth, as you can see in this diagram here, shown by the yellow structure going around the tooth. And it's also called the alveolar bone proper, or the cribriform plate, or lamina dura. So we've got 4 terms for this, okay? And this is why it's often confused. So you can quite clearly see the lamina dura, if you remember on x-rays, where you have the periodontal ligament. The only way we know what the periodontal ligament is usually because there's a slightly whiter structure next to it, and that's the lamina dura, the bundle bone. And then you have the periodontal ligament, and then the cementum and the root surface. Usually this lamina dura or bundle bone is 0.2 to 0.4 millimeters thick, and it's fully lost when the tooth is extracted. You can see on the diagram here, we start with the dentine in the tooth, and then we've got the cementum in between, and then we've got the periodontal ligament, followed by the bundle bone, and then the alveolar bone starts in this region. Yeah. So this is the sort of histological structure. So what happens to the buccal bone after an extraction? Well, buccal bone is very thin. In the anterior maxilla, we know that 60% of patients have less than 0.5 millimeters of buccal bone. Okay, so you consider your teeth, your sort of upper 3 to 3. So 60% of patients have less than 0.5 millimeter of bone on the buccal surface of those teeth. And let's just look at an x-ray. This is a CBCT. You can see this patient is planned for an upper right 3 canine implant, and this is measured at this position on the upper right. Is that the upper right 1 position, and or the upper left one, that may be. And you can see here I've done a measurement of the buccal bone around this tooth, and you've got 0.54. Okay, so if in this situation this patient is in the remainder 40%, they've actually got a lot of bone there, because it's just over 0.5 millimeter. Yeah, 0.54. Now if we talk about the lamina dura being that bundle bone, and it's 0.2 to 0.4 millimeters average in thickness, you can see that we're not left with much bone outside of that lamina dura, are we? You know, so the majority of the buccal bone in the anterior maxilla, we know then, therefore, is classed as bundle bone or lamina dura. And the point is that the buccal bone blood supply is 80% coming from the PDL and 20% from the periosteum. Sorry, we'll just recap there that basically my point there was that when you take out a tooth, you lose the bundle bone. Now that means that if you were to extract this upper central, then if 0.2 to 0.4 millimeters is the lamina dura, you're only going to be left with potentially 0.1 millimeters of buccal bone. And that means you can imagine how friable that is. And so when we take a tooth out, that buccal bone is going to completely collapse, and it's unpredictable if it's going to form there, there, or here. And so what do we do? What can we do to preserve that bone? So buccal bone blood supply. Well, 80% of the blood supply comes from the PDL. And of course, when you take out the tooth, out comes the PDL with the tooth, or is damaged and is pretty much non-existent afterwards. So we know that the only blood supply we're going to get to the buccal bone is 20% from the periosteum. So here's another tooth. As you can see, this patient's got a cervical lesion on the tooth as well, and a very thin amount of buccal bone, primarily made up of lamina dura. And here's a CBCT reconstruction in 3D. You can see a socket, two centrals, and pretty much very thin buccal bone, as you can see here, highlighted in blue there. So what we don't want to do with extractions, we don't want to disturb the periosteum because it's the only remaining blood supply. So if we have to lift a flap, we're going to completely destroy that buccal bone, which is so it's so important to try and do conservative dentistry when we're extracting a tooth, to not only not damage that very thin buccal bone, but also not to have to raise a flap buccally. So we want to aim for atraumatic extractions. How can we do that? Well, we can section teeth if they're multi-rooted, for example, upper or lower molars in particular. We can use luxators, which are need to be driven in the vertical plane rather than the standard couplants that we go horizontally with. We can use something even thinner than a luxator called a periotome, which is very sharp and needs to be handled carefully. Or we can use the Bennex system, which is a system where you screw the a tiny screw into a single rooted tooth, and then use a slightly ratchet device to slowly pull that root out. It is quite expensive, however, which is why most dentists don't have the Bennex system. And let's talk about ARP now. So alveolar ridge preservation. So what are we doing with that? We're grafting the tooth socket immediately after the extraction. And why are we doing that? We're aiming to reduce the bone loss after extractions, because we know if we just take that tooth out, we're going to have a huge amount loss of buccal bone. Varying volume results have been reported with ARP, and because really there's too many factors to account for. You've got different clinical scenarios. You've got infected tooth, you've got a fractured tooth, you've got a multi-rooted tooth, you've got a sclerosed root, you've got different types of graft material, which we'll talk about today, and you've got obviously different operators. So it's very difficult to draw conclusive results about the amount of buccal or vertical bone gain you will get with ARP procedures. What happens when you don't graft the socket? Let's talk about that. So this is a tooth here. Patient presented to me as a post crown. Actually, it survived 20 years, which is huge for an upper lateral, because as we know, upper laterals are one of the thinnest rooted teeth. So when you start to go in there and do a root canal and then have to place a post, you're very much leaving not much room for the root not to fracture. And I was really surprised this lasted 20 years, because usually they don't last that long, and the patient had started to be under stress, was bruxing, and I think that's the reason for the fracture. As you can see, the pathology opened up with a sinus buccally, and we took the tooth out. We didn't graft in this situation. At 3 months, you can see the complete loss in the outline, both vertically and particularly you can see horizontal. Can you see that defect at the mucogingival junction, where they've lost buccal bone? So without ARP, we get greater bone loss and more difficult implant surgery in the future. But this is, as you can see, there's vertical bone loss there, and you can see that there's also horizontal bone loss on that same patient. As you can see how much it's pulled in from where the buccal plate used to be. And you can see if we have to plan an implant at the ideal position, because there's a certain amount of height, as you can see in the yellow, between the implant and the tooth, the crown, this dimension has to be usually a certain amount, and So if we have to place the implant in the right ideal position, we're going to have to place it supracrestal, which isn't ideal either. Okay, so you can see the challenges that we face when we have to place an implant. So it also affects the future of any bridge pontic, as you can imagine, because the pontic has to be very high up in that region if you get vertical bone loss, as well as the horizontal aspect of where the pontic's going to sit on the gum line. So ARP case examples. Let's talk you through a few. Okay, so we've got an upper right two post crown. It's fractured, and we've got the roots remaining. There's insufficient ferrule present for a new crown. We grafted with human bone chips in this situation called allograft, and this is at 4 weeks review, and you can just about see that there's slight bone formation starting at the apex here. You can see some blackening there, but it's starting to infill in this region. Okay, let's just take that back a little bit so you can see that. Yeah. Okay, so alveolar ridge preservation case examples. Number 2, we got a traumatic extraction. We're preserving the buccal plate and the periosteum, very atraumatically taking the tooth out, and there's different techniques for this. We do copious cleaning to remove the granulation tissue or any foreign bodies such as gutta percha, and then we bone graft place. That's the allograft going in, and membrane is placed on top, or either connective tissue graft, or you can go for primary closure or leave it open. There's different techniques. Okay, in this situation it was a hemocollagen sponge sutured down, and you can see at 4-week review a little bit of the allograft is sort of showing its head through there, and beautiful healing. As you can see, the buccal plate, if we sort of draw a line there, the buccal plate has been preserved throughout, and it's still out there. Yeah, that definitely wouldn't be the case if you didn't graft the area at 4 weeks. So let's take it further. So what do we do in this situation? This patient actually had a retainer with the pontics placed there. You can see there's a bit of a color mismatch. The patient was planning on whitening their teeth, and so that's why we went for this whiter color, which actually matches her crown bridges on the upper right region. And yeah, so upper right 2, you can see the design of the retainer positioned here palatally, and really it just looks like a patient's got Invisalign in their mouth, and from a distance it's not noticeable. It's only obviously close up with it on a DSLR that you're going to see it this well. So sources of bone grafting, where can we get bone graft from? So we can take autogenous bone, which is from the host, and it actually can be from the bone or from the host's own tooth. We'll show you that in a second. We can use allograft, which is other humans' bone. We can use xenograft. This is other species bone, usually animals, but there are other types. And we can use alloplast, which is synthetic bone. So let's talk about autogenous bone first. So we can take bone from the iliac crest, which is the hip bone, just above the hip bone, where it's marked in red there. This is obviously done in hospital and usually under general anesthetic or very deep sedation. You've got forearm bones as well, which can be used for bone grafting. In the dental field, in the usual dental practices, if anyone's going to use autogenous bone, usually they're going to take it from the mandibular ramus or the body of the mandible, or even the symphysis. Okay, and this just shows in the sort of the angle of the mandible region, a block graft being taken. This is a block graft being placed. As you can see, screws are positioned. Usually there would be 2 screws, by the way, so to stop any rotational movements. But you can see a block graft in position here. And let's talk about autogenous tooth bone graft. So this is taking the host's host's tooth and chopping it down and making a bone graft out of it. So here, this is what it looks like. Okay, this is bone grafting from a tooth being placed into the jawbone, and this is stitched up. These are courtesy photos from this company here, and it was first developed in 2008 actually, so going back quite far. And what is it? Well, enamel and dentine have similar components to alveolar bone. So in the inorganic component is hydroxyapatite, tricalcium phosphate, amorphous calcium phosphate, and this octocalcium phosphate. Okay, and then the organic component contains type 1 collagen, proteins, growth factors, including BMPs. Therefore, this is what's classed as osteoconductive and inductive. We'll talk about that in a second. Osteoconduction is essentially providing a scaffold upon which osteoblasts can grow into and lay down bone. And we'll talk about what osteoinduction is in a moment. So the teeth must be free of restorations, caries, or endodontic treatment. The issue with endodontic treatment is that there could be ceramic sealers or things which are cytotoxic to osteoblasts. So we don't want any endo-treated teeth. We don't want the caries there because obviously that's bacteria, and we don't want any restorations because that's a foreign object. The tooth, so that's enamel, dentine, any pulp is tissue is okay as long as it's healthy pulp tissue. So we've got this tooth here, and what do we do? First of all, we debride it, and then it's dried, then it's grinded and sorted in special machines, and then it's chemically cleaned. And these are other dentist cases. I haven't used tooth bone grafting, but it's a very rare type of bone graft, but there are some people who stand by it and use it a lot. Obviously, one of the reasons why it's potentially not taken up very much is the risk of introducing caries or bacteria into the bone graft site, as well as the fact that there's a large process to make it, and obviously we know that time is our money is time, and we need to try and reduce that surgery time as much as possible. So this is a situation here. We've got October 2013, the molar is extracted, then it's grafted with tooth bone graft material, and then this is December, 2 months later, the implant can be placed. Got another case here on a tooth, so guided tissue regeneration, and before and after grafting. You can see here just a 1 month follow-up there showing the bone gain. So what other sources do we have? We've got allograft. Allograft is other humans, of course. So human donors, that's usually taken from their long bones. You can get corticancellous granules, as you can see in the lower left, or you can get blocks in the middle, as you can see here. And this is CBCT showing one of my block grafts with the screws in position. You can see obviously we've got vertical bone gain up to here, as well as horizontal, but we obviously don't have any down there, right in the depth of the sulcus. But that's fine because the implant can be placed now in a better restorative position, and we've got plenty of length there. So we also have cancellous granules, so corticocancellous being where the cortex of the bone as well as the cancellous part of the bone is present. As you can see on this bone graft, the white area is the cortical plate, and the spongy material is the cancellous bone. And then we can also get just completely cancellous granules, or completely cancellous rings, which is sort of like bone rings. You have to sort of drill a hole, and then this bone ring goes directly into that hole, and then inside the ring goes the implant. We've got blocks of bone as well in the cancellous form, so this type of blown block without the cortical plates there, that also exists. And you can also mix allograft, so other humans' bone can be mixed with autogenous bone from the host, or with animal bone. We'll talk a little bit about mixing synthetic bone in there as well. You can actually do that, but the most common way that allografts are used is usually these days with the host bone or with xenograft, animal bone. So allograft, other forms of allograft, you can also get allograft from live donors, such as from the femoral head during hip surgery, and some people prefer that to cadavers. And from these live donors, there's a company in Germany which makes 3D custom milled bone blocks with CAD/CAM software, 3D matching the jawbone. As you can see here, the CBCT has taken the bone block is milled in the milling machine, and this is the 3D form, and it should jigsaw match the defect. However, the main problem is the cost. The cost is extortionate. It's around 1800 last time I checked, and obviously with time prices keep going higher, and that's just the 3D bone block without any membrane and anything else that you need to secure it down. So then we've got xenograft. So xenograft are other species. It doesn't have to be just animal. It's just I say animals because that's the most common. We're going to show you what other types of xenograft there are besides animals. Though the most common is bovine, porcine, so from cows or pigs, and also we have horse, which is equine bone. We can also get xenograft from crustacean shells, from corals in the ocean, and algae as well, algae based. They come in granular or block forms, and you can mix them. Again, often they're mixed with autogenous host bone or with other humans' bone, otherwise called as allograft. And here we have an example of a xenograft. This is bovine bone placed in an extraction socket, and we have a porcine membrane here sutured down. This is my case, and this is a 2 weeks review, and you can see granules of the bone graft at the base there, as well as granulation tissue growing over the top. And again, you can see that the buccal wall has been maintained here. If I can just show you here, let's go for dark blue. Should we try that color? Buccal bone there, buccal bone at the extraction time and surgery, and then 2 weeks later, still plenty of buccal bone there. Yeah. So granular bovine bone results, let's talk about that. So that was at 2 weeks, but then you can see at 6 weeks you've still got maintenance of the buccal bone plate there. Okay, and this is at 6 weeks here as well. You can show nice papillae on the adjacent teeth, and this little bit of tissue will gradually resorb. So we've got maintenance of the buccal wall, and we've got maintenance of the adjacent papillae. So then let's talk about alloplasts, otherwise known as synthetic bone grafts. So we've got, they're usually, so this means that they're lab made, yeah? So they can consist of hydroxyapatite, beta TCP, which is tricalcium phosphate. You've got polymers, there are bioactive glasses, and you also have calcium phosphate sulfates. This is not an exhaustive list, but I'm covering sort of the majority of options there are out there. You've got granular forms, a sponge form, you've got putty form, we even have gel forms. And this is a bone graft. This is an ethos placed as a synthetic material. So some studies are mixing synthetics such as hyaluronic acid or hydroxyapatite and beta-TCP with human and animal bone are in the literature, and they're usually done to slow down the resorption of the human or animal bone and make it last longer, or to improve host bone formation. So without going into too much detail, essentially to slow down resorption of the bone graft and to improve host bone growing host osteoblasts into the area. And this is a photo of ethos. It comes in a syringe form, and there are many versions of this out there. So how does bone grafting work? Well, 4 fundamental properties that we want from our bone grafts. We want osseointegration. This is the ability to chemically bond to the outer surface of the bone without an intervening fibrous layer. We need them to be osteoconductive. As you remember earlier, I spoke about that, to provide a scaffold in which the host osteoblast can grow and lay down bone. This is called conduction. Then there's induction. This is to stimulate osteoprogenitor cells to differentiate into osteoblasts. So BMPs and enamel matrix derivatives are what would be classed as osteoinductors. Essentially, they help any progenitor cells to differentiate into osteoblasts. And an example of that is Straumann's endogain, okay, which is an enamel matrix derivative. It's laid down again on teeth which have had periodontal bone loss in order to induce a bone formation. And then we've got osteogenesis. Osteogenesis, the ability to form new bone by actually providing osteoblasts. There's a typo there, or osteoprogenitor cells. So the progenitors before it's differentiated into osteoblasts within the graft material. And this is a photo, my SEM photo of an osteoblast in action. As you can see, that red osteoblast, it's laying down that white bone around it. So autogenous bone is the only one that satisfies all these criteria, okay? However, autogenous tooth material, it's only osteoconductive. It's just providing a scaffold, okay? Allografts can have 3 out of 4 of these properties because they don't have the ability to provide osteogenesis because they don't contain any live cells. Synthetics, alloplasts, these are osteoconductive, and because that meaning they provide a scaffold, but they can also have ability to osteointegrate because they can chemically sort of bond to the bone. And xenografts are mainly osteoconductive, and there's some low-level osteointegration because there's some potential immune reactions that would occur around a xenograft to prevent it from chemically bonding to the host bone. So the role of barrier membranes. Okay, let's talk about barrier membranes. Why do you need a membrane over a bone graft? Well, if you think about it, we need to contain and stabilize the graft material. So this is showing you that the bone graft has gone in. We need to contain that bone graft to stop it spilling out. And this membrane can go over the top or even inside the buccal bone in order to stop it going out through a fenestration. We need to contain and stabilize that graft material because we know that any micro movements of the graft material will result in loss of the graft. They also act as a space maintainer for bone cells to lay down bone. As you can see here, we've got a PTFE membrane on bone. Let's see if we can draw this out. There's the PTFE membrane. You've got some screws or tacks holding it in position. And then the white material inside is the bone graft, and the red is the blood cells and various things such as osteoblasts laying down bone. So we need to maintain that space for the bone graft to grow into, and that's the second reason why we need a membrane. We also need a membrane to act as a barrier to epithelium and connective tissue ingress. So if you remember, and this was taught to me by Dr. Mukesh Soni at Practical Implantology, that the soft tissue cells grow faster than bone cells. And if you did his course, you will know that this is a sort of rough approximation that epithelium grows at 1 millimeter a day, connective tissue grows at 1 millimeter a week, and these are all approximate figures, but bone only grows at 1 millimeter a month. So we got a day, a week, a month. So we need something to slow down and stop the ability for epithelium connective tissue to grow into that defect. So you can see here we've got a membrane represented by the solid and porous layer. Usually they come in a sort of a bilayer structure, and so this is what this diagram is showing. And you can see the bone defect in here where we need the bone to start to grow. We place the bone graft into this hole, membrane goes over the top, and you can see that the connective tissues and epithelial cells cannot grow down because they're blocked by this barrier, and it allows the bone to lay down gradually. Okay, and we also got bioactivation, which is to attract cytokines and inflammatory cells to enhance bone regeneration or angiogenesis. Okay, so this is a more modern concept. Initially, when bone grafts were brought out, it was mainly these three that was known about, and then more recently, scientific studies have shown that actually laying a membrane down can attract these cytokines and inflammatory cells. So that should say cytokines and inflammatory cells to enhance bone regeneration and attract blood supply to the area. Okay. So how long should the membrane last? Well, it's generally accepted that for periodontal tissue regeneration, GTR, we need about 1 to 1.5 months. And for bone augmentation, or GBR, we need 16 to 24 weeks, which is 4 to 6 months of membrane coverage to allow the bone to form. And there's different types of membranes. Let's talk about the membrane options that you have. So essentially, barrier membranes can come in non-absorbable and absorbable forms. Okay, and we're going to talk about non-absorbable initially. And in that, we've got the first developed non-absorbable membranes were actually in the 1980s, including PTFE, which was later developed into titanium reinforced PTFE. Common brand which is out there is Cytoplast titanium reinforced PTFE, and the advantage of non-absorbables is that you've got a strong space maintainer, meaning more bone can be created. Disadvantage is that it's stiff. You can get increased exposure rates of it pushing through the gum or becoming the gum retracting back, exposing the membrane, and therefore there's a risk of bacteria getting in and infection, requiring a second surgery to remove the membrane as well. Okay, besides the infection, you've got to go in and remove that membrane at some point. And you can see here red inflamed tissue around here, and this PTFE membrane has become exposed, which creates a problem in terms of maintaining the space for the bone, as well as the risk of an infection and complete loss of everything. And the exposure rates are well documented. Generally speaking, non-absorbable membranes have about a 20% exposure rate, and absorbable membranes only have a 5% exposure rate. Okay, so PTFE generally around a 20% exposure rate. Titanium, either within the PTFE or as a scaffold, there are titanium scaffolds, and the 20% exposure rate is the norm. Absorbable membranes, we can reduce that down to 5 out of 100. So let's talk about absorbable membranes now. Within absorbable membranes, we can see that there's so many options here within the natural ones as well as the synthetic ones. But within the natural, we're going to talk about collagen today because this is the most common one. And as you can see here, we've got a bone graft down. And this is a membrane, particular brand often tells you where the up portion is, because the bottom portion is rough. It's meant to be for osteoblasts, and the smooth surface is for the soft tissue to sit against. And we can see that within the natural and synthetic subgroups, that collagen, being the natural one, is the most common type that's used in dentistry. And we've got different types of collagen origin. We can use it from pig tissue, porcine, bovine, from cows or other humans. And collagen membranes go through a multi-stage cleaning process where all of the non-collagenous proteins and the antigenic components, which might stimulate an antibody response, they're all removed through special cleaning processes before it's actually sterilized. And the advantages of absorbable membranes are that we get lower exposure rates. So remember, if you remember, 5% as opposed to 20%, therefore a lower infection rate results, and we get improved soft tissue healing because it's a more natural component. It's not seen as a foreign body as much by the body, although it is still a foreign body, but not as much in terms of the way that the body attacks it and heals around it. And also it's radiolucent. So when we place a bone graft and a collagen membrane, we can x-ray and properly see the bone graft to assess how we've grafted. Disadvantages of absorbable membranes. So we've got shorter barrier duration. As you can imagine, titanium meshes or PTFE, they do not dissolve, so you need to do a second stage surgery to remove them, but they last longer. These absorbable membranes are dissolved away by the body's enzymes, and therefore it's a shorter barrier function, meaning less bone will form usually. It can be harder to handle because they can be quite flimsy. There are different thicknesses and materials out there. However, it's a worse space maintainer as it's soft and it collapses under soft tissue pressure or any other pressure, such as a denture, for example. And there's a risk of disease transmission because we're taking it from other humans or animals. Now, within collagen membranes, there are native or cross-linked collagen membranes. And this is it's not an intuitive term, so I'm just going to explain what that means. It's really important you understand that if you go on to replacing membranes. So native means that it's collagen with the natural structure is preserved. Cross-linking is a process to increase the durability of the membrane, make it last longer, and to give it more mechanical strength so that it doesn't rip and tear. For example, a common brand is by BioHorizons, and it's called Memlock. The membrane is called Memlock. And how do we cross-link a collagen membrane? Well, there's different methods of actually making it into a cross-linked form. So UV irradiation is used to make it cross-linked. There's heat, enzyme, or chemical treatments that can be used to make that membrane into a cross-linked function. And cross-linked collagens also have the benefit of lasting longer, but they are less biocompatible. And if they become exposed, they lead to higher risk of infections. That's the disadvantage with cross-linked membranes. So a bit of brand examples here. As you can see, BioGuide from Pointagon. The guy slitch here is taken from porcine dermis, and it's not cross-linked. Okay, so it says class as a native membrane. Memlock, which I talked about from BioHorizons, they come in cow and porcine types, and both of them are cross-linked. Okay, and then there's another one called Jason membrane, which is from pig pericardium. They talk about the heart muscle being a muscle that's got to last. You've got to pump so much, and it's got to be very strong and elastic, and that's why they claim that the taking it from porcine pericardium is useful, but it's not cross-linked, which is useful to us because it's we know that cross-linking, if it gets exposed, it leads to a higher risk of infection, whereas native membranes, they will actually dissolve away and the body will break it down, and they can potentially, in some cases, be left exposed, and there's lots of examples where they're intentionally left exposed, for example, with BioGuide membranes. And as you can see, there's lots of other products, and this isn't an exhaustive list. There's plenty of different companies and membranes out there. And just a few examples. Osmem, if you can't quite see it because my face might be in the way, but is a believe it's a bovine collagen membrane from Ostem. You've got Geistlich's BioOS and BioGuide. I should have had a BioGuide there, is the membrane from Geistlich. And then you've got Memlock from Pyro Horizons. These are some of the most common forms out there. So let's talk about anterior temporization. Now, what I mean by that is why anterior? Well, posteriorly, you don't really need to temporize the site, right? But anteriorly, for aesthetics, you want to give the patient either a denture, a Rochette bridge, or a retainer with a pontic. Okay. Now, why do I want to go for retainers with pontics, and why do I prefer this option? Because, well, first of all, it's increased quality of life. There's no coverage of the palate, so taste and speech can be better tolerated. You've got full control of your taste buds. All that roof of the mouth isn't covered. Of course, that's the same for the bridge. And you've got less of a lisp because you don't have any plastic. There's no flopping around of the device. It clicks into place, and this is the main benefit. It's easy to insert and remove, not only by the patient, but also by me. And I've had so many times where I've got to remove a Rochette bridge and replace it for the second stage surgery or the gum graft or something. And each time I take the Rochette bridge off, it's never in the same form, and it doesn't fit as well. So this is why I prefer to do retainers with pontics if patients will accept it, and it won't damage the graft. Okay. So the point is that with a denture, it may press on the gum line, it may attract bacteria, it may press on the graft, it may press on the implant if you've done an immediate implant. But with Rochette bridges or with retainers with pontic, you do not damage the graft material because you can relieve that area. So let's talk to you more about my favorite, which is the retainer with pontic. And this is a case where 6 months of you've got the option of 6 months of alveolar ridge preservation, waiting for that bone graft to integrate, or you've got the option of taking the tooth out, placing the block graft, for example, or there's other types of granular graft that you can do, and then you wait 6 months as a stage procedure before you load the implant. So you've got 6 months essentially for the process of the bone healing and around the bone graft, and on top of that you've got 6 months for the implant and crown in total. Okay. Roughly you're looking at 12 months that you need to wait, and that you need 12 months for that retainer to last. So I usually make them 3 Duretain retainers. Duretain is a type of retainer brand from S4S, which I'll talk about, and that gives them about 6 months use with each one, and a third one in case they lose one of them. Okay. So let's talk about the referral process first of all, and how you can build these retainers with pontics into your plan, especially if you're going to refer to, for example, me for an implant or a bone graft. If you want to place the implant, you can refer to me for the bone grafting and then do the implant yourself. So you ensure that the patient's suitable. First of all, they've got to be caries and perio free, and the occlusion's got to be okay in terms of space and wear. Explain the consequences of not filling the tooth gap to the patient. Okay, so show them the images, explain that teeth will fall in, opposing teeth, side teeth, your bite will change, it will become harder to clean, the higher risk of gum disease and decay, tooth decay, if you don't replace the tooth. And this is all true. Okay, if you wait long, if we all work long enough in practice, we'll gradually see patients who didn't replace their teeth with the bite changing in that area. Explain the implant is the nearest thing to the natural tooth, and that is sort of, I'd say, the Ferrari of the options that you have to replace your tooth. It's the best option that you've got. Explain that an implant and a tooth on top costs around 2,600, but there are other extra costs in the UK, such as 3D scans and reports and surgical guides and various other things. So really, you've got the consultation appointment, you've got 3D scans, you've got potential for bone grafting, etc. So usually implants will reach you in the 3 to 4K region, if not more. So it's the Mercedes-Benz option for missing teeth. Perhaps Mercedes-Benz is a better analogy than a Porsche or Ferrari, because Mercedes is a much more sort of generally accepted term across all age groups, whereas Porsche and Ferrari might just be for your boy racers, right? So explain to patients that you can spread the cost over 12 months usually, or longer with most implant surgeons. If the patient is interested in implant, fill out the referral form. I personally charge £150 for my implant consultation. And at the end of this appointment, I will consent the patient for a retainer with a pontic and then refer back to you. You then make 3 retainers for £595 as a sort of starting price. You can increase that should you wish. And it's much more than an NHS band 3 denture, but it's much better value for the patient. And that's the way to talk about it. It's less than double the cost, but it's way better value. So you book a 30 minutes retainer impression appointment. Use a good alginate such as Hydrogum 5. Take upper and lower impressions, send it to S4S, which is a premium lab in terms of making retainers. Request 3 Duretain retainers. These are much stronger than Essex's. I've made Essex retainers before, and they break in about 3-4 weeks. Duretain retainers will last, okay? Ask them for a painted pontic. There are options to add an acrylic tooth within the retainer. These can come loose and they won't fit as well. I prefer it when they paint the pontic. You can buy pontic paint. Well, the lab can. You can buy it yourself, of course, but you want the lab to do all the sort of the work on here. So they ask them to paint the pontics and not to place a tooth pontic. So you need to specify that. You get a 2-week return. Book 20 minutes fit. You might need to do some adjustments for the retainers to fit them and make sure that the patient is able to remove and insert them. Lab cost is going to cost you around $220 for 3 Duretain retainers with a single pontic tooth, painted. Charge $595, meaning you get a profit of $375 for 1 hour of your time. That's based on 30 minutes for the impressions, 20 minutes for the fit, and potentially 10 minutes for a review, or if you need an extra 10 minutes to actually do some more adjustments. Okay, so here we've got an example of Duretain retainers, and I've worked on my prescription to the laboratory, and this is quite a very long prescription. So we've got a protocol that you can ask for when you write to S4S. You can ask for the NAS protocol, okay, and you can ask for 3 Duretain retainers with a painted pontic on upper right 2, for example, due to be extracted at fit. Okay, this is the only part that you need to write. The remainder you can say as per NAS protocol, and all of this stuff that I'm going to highlight in green here downwards will be part of the protocol that's already on their file. So what I've asked them to do, and I've worked with S4S a lot on this, they're a very understanding lab. They have good technicians who they've been there for many years, and I've worked on this protocol to make a very good retainer. Excuse me. So what they do is they ensure that it's not engaging missing teeth undercuts, because then that's when you have problems inserting and removing them. They make sure that it's removable and insertable with a mild amount of retention. They also check that the occlusion is stable. They scallop all the retainers, meaning that this will not exist on your retainer. So this sort of outline here, so it will follow the gingival margin. We don't want this plastic above there, because it will impinge on gingivae keratinized tissue. It could cause recession, it could cause ulceration, and bone graft damage as well. So they scallop all the retainers. You need to, of course, give them the shade that they need to place there. They won't know that, and the return date. I usually say, so 2 weeks minus a day, and then so you get the patient back at the 2-week mark, but you ask for a return 1 day before. Any issues, you can ask for the lead technician, Will Lyons, and this is the address, telephone number, and email for S4S lab. Okay. All right, so I hope you enjoyed that lecture, and we're obviously going to have some questions at the end. If you want to gain your CPD credits, remember I need these three details from you, either if you filled out the online form or if you're going to message me separately, and we will send you the CPD feedback, the lecture PDF, and a referral form, as well as S4S will send you out an introduction pack and a 50% discount on your first case with them. Please let me know if you don't want that third one. Okay, the S4S introduction. And just to finish a little bit more about my travels, it was a period I took 2 years off work, went traveling around the world instead of buying a house, which I regret now, but I had the best time of my life. But this is the Salar de Uyuni, which is the salt desert in Bolivia. And this is me salsa dancing. I used to teach salsa in Newcastle. This is one of my performance groups. And this is me scuba diving in Thailand. And this is hiking in a mountain in Latin America. And this is on a glacier in Argentina. So some references also, if all the references for all the knowledge and information here are in these papers. I hope you enjoyed the lecture. And just to finish, this is me. There's my email, Instagram account, and I take referrals for all these things: oral surgery, crown lengthening, functional and aesthetic, periodontal treatments, both non-surgical and surgical treatments, bone grafting and implants. And if you want to work with me on any of these things, of course, I will send the patient back to you for the rest of the treatment, such as, for example, if you've got an implant patient who's got perio, you want to stabilize their perio, I will stabilize the perio and write back to you, and then you can then place the implant. Same goes for bone grafting. If you've got a big defect that you need grafted, then of course send them to me and I will graft and return back to you for the implant. Or if you've got any of the other procedures that you want doing, I'd be happy to answer any questions. Okay. Thank you very much, and hope that was a general good overview of bone grafting and why we do it and what techniques we have available. Thank you for joining. Cheers.